Hello friends, today we are going to discuss about EASL clinical practice guidelines on liver transplantation. So level of evidence is 1, 1, 2, 3 for mention. So 1 means based on systemic review of randomized control trial. 2 is RCT or observational studies. 3. Non-randomized control cohort follow-up studies. 4 includes case series, case control studies. 5 is expert opinion. Then strong means strong grade of recommendation. That means shall or is recommended. Weak or open can or may suggested. So let's have a look. So should there be upper age limit for liver transplant recipient? Potential candidate for liver transplant should not be disqualified only on the basis of age alone. The assessment of candidacy for liver transplant in elderly population should include cardiopulmonary, frailty, sarcopenia, nutritional status, anatomical and surgical factor, as well as age and risk-based screening for asymptomatic malignancies. So it should not be the hard and fast criteria when it comes to liver transplant. But yes, we should consider other factors like cardiopulmonary, frailty sarcopenia, nutritional status, surgical factors, and risk factors based screening for asymptomatic malignancy. So does sex have an impact on access to liver transplant among wait listed patients, or should we have sex-adjusted male allocation system? So new allocation system should be implemented to address compromised access of female to liver transplant, and it has a strong recommendation. Should patient with ACLF grade 3 be considered for transplantation? So patient with the ACLF grade 3 should be evaluated for liver transplantation. So patient with the ACLF and more than 3 organ failure, according to the Cliffs C organ failure score, than 64 should be re-evaluated daily and only listed for liver transplant when organ failure and ACLF grade improves to less than 3. In case of respiratory distress syndrome or high lactate level, the indication for transplantation should be conscious decision as this is associated with increased post-operative mortality. Now, what about active severe autoimmune hepatitis with liver dysfunction? So those patients with the acute severe autoimmune hepatitis should be considered for early corticosteroid therapy before hepatic encephalopathy onset. Now, the patient with acute hepatitis with severe encephalopathy and encephalopathy 3 or 4 should not be treated corticosteroid but should be considered for early liver transplant. And it has very strong recommendation. So if the corticosteroid has role, then it is recommended only hepatic encephalopathy onset. Now the patient with the severe autoimmune hepatitis, if they are not steroids, then it should be considered for early liver transplantation. Now about the Wilson's disease with the severe neuropsychiatric manifestation. In patient with the Wilson's disease and end-stage liver failure, neuropsychiatric manifestation should not preclude the referral evaluation and waitlisting for the liver transplant. Patient with the Wilson's disease and isolated neuropsychiatric manifestation should ideally be referred for evaluation by multidisciplinary team at liver transplant center. The decision to proceed with liver transplant screening may be taken on case-by-case basis after careful discussion only. Now about selection of liver transplant candidate. Now criteria should be used to select patient with history malignancy in remission for liver transplant. So, if the patient has a history of recently treated normal or those who have undergone curative therapy and are tumor free in remission should undergo multidisciplinary assessment for suitability and timing of liver transplant that include detailed cancer and treatment specific information, including recurrence-free survival estimates and therapeutic options for potential post-liver transplant cancer recurrence. Patients with the active malignancy should be excluded from the liver transplant waiting list except those with selected indolent and very low-grade cancer. Now, what are the recommendations for coronary artery disease? So, coronary imaging, invasive, non-invasive, should be considered as an initial strategy in liver transplant candidates who are at high risk of significant coronary artery disease. It has very strong recommendation. In liver transplant candidate, unrevascularizable significant coronary artery disease, that is defined by more than 50% stenosis in more than one segment of three major coronary artery or more than 70% stenosis in moderate sized branch vessel, should be considered contraindication for liver transplant. And remember, it has a very strong recommendation. That's why it's very necessary to undergo CAG before transplantation if we are suspecting this coronary artery disease, or if the patient is having the if the patient is on the high risk of coronary artery disease. So let's have a look how to deal with this. If there is some candidate who is posted for the liver transplant and it has an established heart disease, then immediately we have to take cardiology reference. If not, then at least he should undergo some basic tests like ECG, transthoracic echocardiogram. If it is normal and if the patient is at the high risk like diabetes mellitus and other coronary artery risk factors are present, like if age more than 60 years, dyslipidemia, hypertension, left ventricular hypertrophy, family history of CAD, tobacco use, then we need to go for repeat ECG and CTEE, transthoracic echocardiography. If all these risk factors are there, then we need to go for invasive coronary angiography. And according to the criteria, if it is matching that criteria, then yes, that is contraindication for liver transplant. As we have seen, if there is a significant coronary artery disease with more than 50% stenosis in more than one segment of three major coronary artery or more than 70% stenosis in moderate size branch vessel, then it's a contraindication for liver transplant. Now, how to deal the patient with the obesity? In patient with the obesity with the compensated cirrhosis and BMI more than 35 without clinically significant portal hypertension, bariatric surgery must be considered in center with expert experience in both liver transplant and bariatric surgery. It has weak recommendation. In patient with obesity with decompensated cirrhosis and BMI more than 35, bariatric surgery should be considered only at the time of liver transplant and thereafter. Again, it has a very strong recommendation. Sleeve gastrectomy should be proposed as the technique of choice in selected patients with obesity and with well compensated cirrhosis and in setting of liver transplant. Again, it has a strong recommendation and strong consensus. Now about the portopulmonary hypertension. In patient with the compensated liver disease, pulmonary hypertension alone is not an indication for liver transplant. It has very strong recommendation. Vasomodulator therapy should be offered to all liver transplant candidates with the portopulmonary hypertension and mean pulmonary artery pressure of more than or equal to 35 mmHg and pulmonary vascular resistance of more than or equal to 3 Woods unit. Again, it has a very strong recommendation and strong consensus. A mean pulmonary artery pressure of more than 45 mmHg despite vasomodulatory treatment, should be considered as an absolute contraindication to liver transplant. In patients with the portopulmonary hypertension in need of liver transplant, an adequate hemodynamic response to vasomodulatory therapy is required to proceed through transplant and should be defined as mean pulmonary artery pressure of less than 35 mmHg and portal vascular resistance of less than 5 Woods, or mean pulmonary artery pressure of 35 to 45 mmHg and portal vascular resistance of less than 3 Woods. Again, it has strong recommendation. Now, when patient with cirrhosis should be evaluated for combined liver and kidney transplant. In the situation of cirrhosis with chronic kidney disease, combined liver and kidney transplantation is recommended in patients who are on dialysis for end-stage renal disease or have most recent EGFR and creatinine clearance value of less than 30 ml per minute. And again, it has a strong recommendation and strong consensus. In the situation of cirrhosis with the chronic kidney disease, for which reversibility is uncertain, both simultaneous and sequential liver kidney transplantation is recommended. Again, it has very strong recommendation and also strong consensus. In the situation of cirrhosis associated sustained acute kidney injury, simultaneous liver kidney transplantation is recommended in patient with the GFR of less than or equal to 25 ml per minute or on hemodialysis for at least last 6 weeks. In patients with compensated cirrhosis who are candidate for kidney transplant alone can only be proposed in the absence of clinically significant portal hypertension. The diagnosis of clinically significant portal hypertension in this situation wants demanded specific studies. Now about frailty, sarcopenia, malnutrition. Is there any contraindication for liver transplant? Let's see. So during pre-transplant evaluation, all patients with cirrhosis should be assessed for the frailty. Frailty per se should not be considered as a contraindication for liver transplant. Any frail patient should be evaluated for rehabilitation and nutritional support. Now, what about complete portal vein thrombosis? So, anticoagulation is recommended in liver transplant patients with cirrhosis and newly diagnosed bland portal vein thrombosis. It had strong recommendation and strong consensus. Transjugular intrahepatic portosystemic shunt procedure should be considered in selected transplant candidates with portal vein thrombosis. Again, it has strong recommendation and weak consensus. Now about liver transplant oncology. Patient with HCC beyond Milan criteria. Selected patient with hepatocellular carcinoma beyond the Milan criteria should be considered for liver transplant if downgraded to within Milan criteria or other criteria according to country allocation system criteria. Patient with unresectable HCC who present with AFP of more than 1000 should not be considered for transplantation except when treated with liver-directed therapy resulting in significant sustained and persistent decline in AFP levels. It had strong recommendation and strong consensus. Patient with HCC treated with immunotherapy be managed before transplantation. Immunotherapy may be given with caution to patients with HCC who are on transplant waiting list or whenever feasible. Immunotherapy should be stopped to allow for period of washout prior to transplantation to reduce the risk of refractory rejection, though the optimal interval between completion of therapy and liver transplant is not known and may be impacted by pharmacokinetics of immunotherapy. How should patient with unresectable colorectal liver metastasis should be managed? So well-selected patient with unresectable liver-only colorectal metastasis may experience improved survival following liver transplant and thus may be considered for transplantation within the setting of clinical trial given that result to date are limited by length of follow-up, relatively small number of patients, and uncertainty regarding survival outcome for comparative group treated with contemporary systemic and surgical therapy. Patient with unresectable liver metastasis from neuroendocrine tumor, how we should manage. Selected patient with unresectable liver only neuroendocrine tumor metastasis who have had primary tumor resected followed by period of disease stability may be considered for liver transplant in centers who are experienced in treating neuroendocrine tumor. Now, how we should deal with unresectable intrahepatic cholangiocarcinoma? Patient with cirrhosis and small unresectable intrahepatic cholangiocarcinoma may be considered for liver transplant, ideally within the setting of clinical trial and ideally treated on waiting list with liver directed therapies such as ablation, transarterial radioembolization, and transarterial chemoembolization, depending on anticipated waiting time. Now, patient with early stage unresectable perihelar carcinoma treated with neoadjuvant chemoradiotherapy. Highly selected patient with unresectable early stage perihelar cholangiocarcinoma may be considered for treatment with neoadjuvant chemoradiotherapy followed by liver transplant. Now about liver donors. Now, should we consider liver donor with active hepatitis B infection? Anti-HBC positive HBsAg negative organ should be used for transplantation independently of HBs status of recipient, provided that recipient is adequately vaccinated or there is option of indefinite prophylaxis with nucleoside analog. HBV uninfected patient with short life expectancy on waiting list and the use of HBs AG positive graft can be considered if there is option for indefinite treatment with potent nucleoside analog. HDV is absent in the donor and the recipient, and the graft quality is adequate, and the recipient provides informed consent. So, should we consider liver donor with HIV infection? The use of liver donor with HIV infection can be considered only in HIV infected recipient if there is option of effective indefinitive anti-HIV therapy and the recipient provides informed consent. Now about liver donor from active SARS-CoV-2 infection. Liver donation from the SARS-CoV-2 positive donor should not be contraindicated. SARS-CoV-2 monitoring of recipient should be provided and antiviral should be administered in case of SARS infection considering drug-to-drug interaction. Again, it has strong recommendation. Now, liver donor with the cancer. In case of donation from the donor with the known history of cancer, the risk of cancer transplant transmission versus risk of death on waiting list before suitable graft without such a risk would become reasonably available should be weighted, and individual based decision and shared decision of transplantation should be made if the risk of death on waiting list outweigh the risk of cancer transmission and recipient provide informed consent. Now, what about the liver donor with the familial amylotropic polyneuropathy? Liver transplant from donor with the familial amyloidotic polyneuropathy can be considered in the selected recipient. Familial amyloidotic polyneuropathy, close monitoring for early detection of de novo transthyretin neuropathy, cardiomyopathy should be performed. Now about the risk factors for control donation after circulatory determination of the death. So independent risk factors are donor more than 60 years, donor mom ischemia more than 30 minutes, Graft cold ischemia more than 6 hours, recipient MELD score more than 25, and recipient retransplantation. Thus, there is evidence to date support the use of uncontrolled DCD liver from transplant, or should this form of donation be actively pursued. Both donor and recipient risk factors should be considered in order to optimize controlled DCD liver transplant outcome, while combining several risk factors should be avoided, or else the application of advanced perfusion preservation strategy should be applied. Livers from uncontrolled DCD donor recovered with normothermic regional perfusion should be restricted to a recipient in whom risk of continued waiting outweighed the risk of adverse post-transplant outcome. Now about the evaluation of the liver donor candidate should be performed according to established protocol, and it includes liver anatomical, parenchymal and volumetric assessment, age and sex, appropriate screening for clinical relevant as well as silent comorbid condition, including procoagulant condition, MASLD, then cardiovascular disease, cancer, infectious, in the other potentially transmissible disease, and psychosocial risk. Liver donor liver remnant should be at least 30% of pre-donation volume or mass. Now about liver donor assessment and the prerequisite. So donor should be healthy between the age of 18 to 60 years. He should be free willing to donate. He should understand the entire donation process associated risk, including up to 0.5% risk of death, no comorbid condition, including obesity, psychiatric, and mood disorder. Up-to-date cancer screening performed in accordance with the age, sex, and history of known exposure. Screening of infection and other transmissible disease performed in accordance with the area of origin and history of known exposure. Then ABO compatible with intended recipient. Minimal to no hepatic steatosis. Liver remained more than 30% of pre-donation liver mass. Now, what evidence is there to support donor-recipient matching? Does donor-recipient matching improve the post-transplant outcome? And does the donor-recipient matching impact the organ utilization rate and allocation system? So, though the novel liver allocation system, including one of the donor-recipient matching, may offer certain advantage relative to male, their use cannot be recommended as of yet due to lack of robust clinical data. Now about immunosuppression strategies. Tacrolimus trough level should be kept at 6 to 10 during first month, followed by 4 to 8 thereafter. It is recommended to combine tacrolimus with other immunosuppressant drugs like MMS, azathioprine, and mTOR to allow for lower range of tacrolimus trough level than the recommended for monotherapy and to help preserve renal function. The administration of basiliximab induction with delayed introduction of tacrolimus is strongly recommended in patients at risk of developing post-transplant renal dysfunction. Is there a specific immunosuppressive regimen for patients at high risk of cancer after liver transplant? Exposure to this CANI should be minimized by employing combined immunosuppressive regimen, preferably mTOR in case of high risk of hepatic and extrahepatic cancer recurrence. mTOR-based immunosuppression regimen is strongly recommended in patients with a history of recurrence, de novo non-melanoma skin cancer. Is there any role of immunological risk stratification either before and after liver transplant? Screening for performed DSA should be performed in recipient at the risk of humoral sensitization. Patient with the high level of preformed DSA should receive more intensive follow-up than those who do not have detectable preformed DSA. Monitoring for the DSAs in combination with the alanine aminotransferase and other non-invasive tests such as transient elastography may be recommended to identify liver transplant recipient at the risk of exhibiting subclinical rejection in whom aggressive immunosuppression minimization would not be available. In the presence of high mean fluorescence intensity DSA, minimalization is not advised unless allograft damage has been excluded by performing liver biopsy. So, is there any recommended treatment for acute and chronic AMR diagnosed on the basis of recent Banff criteria? In patients with the combined acute T cell mediated rejection and antibody mediated rejection, T cell mediated component may be the first, may be treated first according to the each unit standard care. Treatment with the plasmapheresis and intravenous immunoglobulin is suggested in patients who do not respond to this approach. In patients with the persistent site of antibody mediated reaction who do not respond to regimen outlined above, second line therapy must be considered, like rituximab, eculizumab. In patients with the diagnosis of probable chronic AMR, according to the current ban of criteria, exhibiting raised transaminase, at least moderate inflammatory infiltrate, may be treated by intensifying conventional immunosuppression regimen. Our induction of operational tolerance and attempt at immunosuppression discontinuation feasible. Complete withdrawal of immunosuppression should not be the aim of standard care, even in the case of extended rejection free post-operative course. If immunosuppression is completely discontinued for individual reason, close monitoring of rejection that include histological assessment should be guaranteed. Now, what are the best strategy to prevent and treat relapse to alcohol use following liver transplant? To prevent alcohol relapse after liver transplant, multidisciplinary team, including transplant hepatology surgeon, psychologist, psychiatrist, and addiction specialist, should be involved in all stages of the transplant procedure, including assessment during evaluation process and long-term follow-up. Pattern of alcohol consumption should be included in the multidisciplinary evaluation. If the patient fulfills the criteria for alcohol use disorder, pharmacological treatment and behavioral therapy, either before and after liver transplant, should be considered. If there is discrepancy between the patient's self-reported alcohol consumption and clinical suspicion of alcohol intake, then the routine screening of alcohol biomarker should be performed. This can be done using ethyl glucuronide in urine, possibly hair, and the phosphatidyl ethanol in blood and other appropriate tests. Treatment of alcohol relapse after liver transplant should involve multidisciplinary team. Now, metabolic associated steatohepatitis. To prevent recurrence, metabolic risk factors should be addressed and treated. Healthy lifestyle and the pharmacological treatment of the complication should be aggressively pursued. When there is uncertainty in regarding recurrence and de novo metabolic steatohepatitis or other cause of liver disease, then the liver biopsy is suggested. Adjustment of immunosuppression should be considered according to the kind of associated complication, but should be balanced against the risk of rejection. Now about autoimmune liver disease, ursodeoxycholic acid should be given lifelong after liver transplant to all patients with primary biliary cholangitis to prevent recurrence. For transplant recipient with the primary biliary cholangitis, no immunosuppressive therapy should be recommended in order to prevent disease recurrence. In transplant recipient with the autoimmune hepatitis, corticosteroid withdrawal to avoid long-term steroid-associated side effects should be performed cautiously due to risk of disease recurrence. There is no specific immunosuppressive regimen or treatment effective in preventing primary sclerosing cholangitis recurrence. Thank you, guys.